Good morning, ladies and gentlemen, and welcome for today's webinar. My name is Vincent Kimathi. We are coming live from ICJ Kenya studio. I will be joined by Santana Simiu, who will be co-moderating today's session. The preamble to the report of the National Task Force on Mental Health begins by quoting His Excellency President Uhuru Kenyatta's Madaraka Day speech of June 2019. In his remarks, His Excellency spoke profound words portraying a husband, father, and grandfather. He said, "Depression has today become a common phenomenon, and it affects persons from all walks of life and ages. I urge employers and institutions of learning to invest more time and resources in monitoring and facilitating the mental well-being of their charges. I, therefore, direct the Ministry of Health in consultation with county governments, Ministries of Education, Labor and Social Protection, and Public Service, Youth and Gender Affairs to formulate an appropriate policy response. In so doing, he gave a voice to millions of Kenyans whose silent suffering in the face of challenges of poor mental health and reached unacceptable levels."
Article 246 of the Constitution of Kenya creates the National Police Service Commission, whose mandate is to independently look at police welfare, career progression, and other aspects of human resource management. Many police officers welcomed the creation of the commission. It created hope for fair recruitment, appointments, transfers, promotions, and disciplinary control, thereby potentially bringing to an end to the corruption and nepotism that had afflicted these processes. Prior to April 2019, training of police officers emphasized work-related skills. However, in light of recent trends, the Inspector General of Police has placed an equal emphasis on the mental wellness of police officers in a bid to improve on service delivery. In response to the rising cases of murder-suicide within the police, National Police Service has embarked on an ambitious program to sensitize all police officers in trauma healing and psychological well-being. The plan is to give officers tools to recognize trauma in themselves, other officers, and the community, improve skills and approaches to facilitate peer support, and amplify processes that enhance the role of police stations as avenues of healing of officers and the community at large. It is hoped that these systems will facilitate an environment where officers are free to share, vent, counsel each other, and hopefully avoid pent-up stress that bursts into destructive bouts of violence.
In the recent past, ICJ Kenya and members of the Police Reforms Working Group have noted with concern an increase in the cases of police suicides, attacks by police officers on colleagues and family members due to unaddressed mental and psychosocial issues. The incidences have sparked discussion on the underlying reasons that these incidences are steadily on the rise. A concern is that the spike in cases is associated with trauma that police officers confront in discharging their duties. In compiling its report, the National Task Force on Mental Health interviewed Kenyans, and some police officers reported continued stigma at the workplace. The report states that patients who had substance use disorders or other mental illnesses were ridiculed when they eventually returned to their workstations. A police officer mentioned that once one is designated Mike Papa, the fellow police officers, it is nearly impossible to work in that station. The report further placed an obligation on the Ministry of Interior to develop and implement a mental health literacy curriculum for the National Police Service, Prison Service, and Defense Forces. The report made a rallying call to legislators to engage, make amendments, and enact the Mental Health Amendment Bill that would safeguard the rights of persons at the national and county level. Ladies and gentlemen, it is upon this background that we are hosting this discussion today. To help us unpack the issue, we are joined by nominated Senator Sylvia Kasanga, President of the Kenya Psychiatric Association, Dr. Boniface Chitai Murabula, and Ms. Sarah Muthiga, who is the Manager, Legal and Policy Affairs at the National Police Service Commission. We also invite your comments and questions on these conversations via our various social media platforms. We also want to remind our participants that we are live on YouTube And you can continue engaging us via our Twitter platform at ICJ Kenya.
We will kick off the discussion with Dr. Boniface Chitai, who will put mental health in perspective. Daktari, statistics show that a fourth of the population in Kenya have either suffered mental illness or are currently suffering mental illness. And keeping in mind that May is Mental Health Awareness Month, mental health has really been stigmatized in Kenya. So kindly please tell us what is mental health and how does mental illness manifest, and what is the importance of getting help early when a person is undergoing emotional distress. Over to you.
Yes, thank you, Santana. Please allow me to answer the questions progressively, and then you can ask me the subsequent ones afterwards. But just to begin, first I want to thank ICJ for hosting this discussion on mental health. We know that mental health has been that subject that is hardly discussed, not just about the police, but generally in the community. And I'm just happy that we are here discussing the mental health of an important segment in our society, the security players, the police, who play a vital role in our community. I want to start by saying that it's not really mental health that is stigmatized, but rather it is persons living with mental illness. It's important for us to be clear that it's actually persons living with mental illness that are stigmatized. And why is that so? It's because mental health itself is a good thing overall, because if I say that I have good mental health, it's a good thing. It means that I'm in that state of well-being where I can be able to cope with stresses, where I can be able to work and be productive, where I can be able to contribute to the community, where I can be able to form and sustain relationships. And that's a good thing. And how is that possible? It will be possible if my thoughts, my feelings, and my behaviors do not cause distress to either myself or those around me. So that is really the sum total of mental health. But it's always important to say that mental health is part and parcel of our overall health. So that if somebody is in poor mental health, their physical health will likely also suffer. And if someone is in poor physical health, their mental health will also suffer. An example is, if I have depression, I may experience headaches. I may experience, I could engage in risky behavior as well because of the depression. And if I'm also on medication, I may even not take them for other conditions, let's say diabetes and so on. But if also I have a fracture of my leg, then I will definitely be in distress because of the pain, and therefore I will also suffer as a result. And I may suffer from anxiety, and sometimes I could suffer from depression because of that physical pain. And we find that a lot of times when people are suffering from conditions that have them in chronic pain and that are untreatable, a lot of times they suffer depression and sometimes they become suicidal. So really that's the background of what mental health is, Santana.
Okay, thank you. You've partly answered the second question when you spoke about depression, a person undergoing depression and having headaches and engaging in risky behavior. But I would like to ask, so how does mental illness manifest? How would you detect it in either yourself or in someone?
Yes, so mental illness is not one disease. That is the most important, that's the take-home message, that mental illness is not one disease. Mental illness is a collective term for many diseases, almost 200, that manifest differently in different people. So there are almost 200 conditions, and depending on the condition, there are those who will continue living with very slight difficulty, and they'll continue doing their work and so on with just some distress. But then there are conditions where if you suffer from such, let's say something like, let's say, schizophrenia, may be very difficult for you to operate. But also for each condition, there is always mild to severe. So you could have mild forms of OCD or obsessive compulsive disorder, which really just gives you a little difficulty. But then if it is severe, again, it interferes. So it depends on the condition, but also on the severity of the condition. So then in general, we cannot speak really conclusively about symptoms or general symptoms of mental illness because there are many different illnesses. However, one important thing to look out for always is change. What change is taking place in an individual from how they are functioning previously. So that is the most important thing. Change, either in myself or in my friend or in my family member, I look out for change. Someone who was jovial now is sad all the time. Someone losing their appetite for food, and someone feeling that they have no hope and withdrawing from life, poor memory, you now think about death all the time and speak about it. Probably that could be a sign of depression. If someone is hearing voices of people that are not there, most of the time you will think that it's just a joke, but then for them, they are hearing these voices, which in most cases they're telling them bad things about who they are, and sometimes commanding them to harm themselves. And so that could be a sign of a serious illness like schizophrenia. As some symptoms could be that someone perhaps is extremely energetic, they have so many plans, they're talking a lot, and so on. And that could be that they have bipolar. So all these are symptoms. But what is important is what change is occurring in the person's life from how they were before. That is the one thing that we have to look out for. And if this change especially is sustained for long, then it's usually a possibility of a mental illness, something going wrong. You look at somebody, a human being may not sleep for like 1 or 2 days. Maybe they are under some distress. But if you've gone for 1 week, 2 weeks without sleeping, it becomes a very dangerous sign that something may be going wrong. Or if you miss your sleep. So how long are you having these symptoms is also a very important thing. And also, what else is happening? If, for example, you've lost somebody dear to you, it is normal in the grieving process to feel distressed. You'll feel sad. You may be unable to sleep or eat. But over time, depending on your culture, when the burial is over and now there are always even rituals to help people move on, like shaving of head and so on. So signaling that people actually come back to their normal lives. And so, but so in such circumstances, that cannot be said that it's a mental illness. Stresses due to various issues in life, such as maybe school fees, when schools are opening, is not described as mental illness. So these short-term stresses that come and you feel distressed is not mental illness. But mental illness is when you have a couple of symptoms that are not part of who you've been, but they're distressing you or distressing others, making it difficult for you to function. Then that is likely some mental illness going on.
Thank you. So perhaps I think the biggest challenge we might face is how do you differentiate the day-to-day stress and a person undergoing mental illness? And so at what point should someone get help? Either whether it's yourself or someone else, at what point do you think, what signs will show that a person needs help? And yes.
Yes, Santana, thank you very much. I'm always careful about drawing a line between who should go to the doctor and who should not. I'm always very careful. What I would like everyone to know, both me, you, everyone listening, is to understand that we can all suffer from mental illnesses. It is this notion, this myth that mental illnesses affect only a small group of people who probably their parents had mental illness. Those are the ones affected. It should be someone very far from you. So we deny the truth that we could actually suffer from mental illnesses. We have a very high probability ourselves of suffering from mental illnesses because we live in a world that is stressful and we have brains. And when you stress these brains, sometimes you encounter mental illness. So as soon as you've seen a change, I mean, don't wait for the big, challenge, because that could also signal that it's too late. Don't wait to start experiencing these strong thoughts about dying. And that's when you say, okay, now I need to go and see a doctor. As long as you experience changes that are distressing, you are now not sleeping well. You are now sad. If you now feel that you're withdrawing from activities, or you notice that your friend is withdrawing from common activities that you've been enjoying together, should you have these changes in your life without any good explanation, it is good to go and see a doctor. Going to see a doctor does not always mean that you come out of from the doctor with a diagnosis. So the visits could help to simply screen, find out if there is any illness. And sometimes someone walks in, and you realize, okay, they're just going through stress because of a specific reason. And in that case, you just advise them on how to cope with that situation. So let's not be afraid. Sometimes we are afraid that going to the doctor means atakupatia diagnosis, alafu atakupatia madawa, alafu hiyo madawa itakufanya ukuwe zombie. Those are the misconceptions out here. So just walking to a doctor, the way Kenyans will be very proud to go to say, I've gone to Karen for my medical checkup. I've gone to Aga Khan to see my cardiologist. I've gone to do a pap smear. We are proud to say these things, but we have not yet embraced the idea that you can go to a psychiatrist for mental evaluation, have a conversation, discuss issues, and come out without any medication really, but with some good advice about your mental health. That helps. Yeah.
Thank you. So back to the discussion today. What do you think in the work of police? What do you think impacts their mental wellness?
Yes. What impacts the mental wellness of the police?
Yeah.
I think I wish this question would have actually been posed to the police, but I've sort of listened to them. In fact, in the last 1 week, I was having a few sessions with the police officers working in the coastal region, and I listened to some of them, and some of them are very young. First, I must say that I met very patriotic men and women who struck me as being very committed, to their work, and who have a desire to actually deliver. But one of the problems that face them is frustration. And frustration means that they have this desire to do the work, but they don't have the capacity to do, or they don't have the instruments to do it. They don't have the facilitation to do it. Things like lack of vehicles in the police station, lack of stationery in the police stations. This leads to frustrations, and these frustrations actually are the ones that can contribute to mental illness. Issues like trauma, and that's very important. Police officers in the line of their work, they are supposed to do work that sometimes is very dangerous. They're the ones who are supposed to be first responders when there are disasters. So nyumba ikianguka mahali, they are the ones who are supposed to go there. During very serious accidents that most Kenyans want to keep away from, the police are expected to go to the scenes and interact with the injured people, and sometimes those who are also deceased on the scene. I can tell you that this is extremely difficult work. It's very painful work. So police officers encounter a lot of pain in the course of their work. And this pain then can lead to what is called a secondary traumatic stress. Just because you're witnessing the pain, then also it starts to affect you. It elicits in you negative emotions, anger, sadness, and this feeling that the world is a very cruel place. And you see, look at them also encountering robbers and armed people and so on. It's a problem. Thirdly, I will say issues to do with public perception. Everywhere in the world, police officers are perceived negatively. It does not matter whether you are living in UK, in Norway, in Canada, in Australia, in Kenya, in Uganda, police officers are always perceived negatively by the public. And obviously this affects their work because sometimes the criticisms that we lay on them is very harsh. Number 4, I could say that the fact that the police force and discipline forces work within a command system, I'm very sure that at some point police officers receive instructions that go against their core beliefs as human beings, but somehow they are supposed to carry out those instructions, and especially if these instructions are coming from politicians, and where now they have to serve some political. They could have, I mean, politically they could have been of different persuasion. Of course, they are politically neutral on the outside, but then they are sometimes forced to do. They could be forced to harm, really, when it's against their core beliefs. And experiments have been done in different places to just investigate how a human being will respond to instructions from a superior. And it was found that one can actually do something that is totally against their own beliefs because the instruction is coming from above. So police officers definitely will suffer from the guilt of carrying out some activities that go against their core beliefs. And then now issues of jobs, or issues that have to do with the labor issues around the police officers. Police officers, according to the law, I think they're not allowed to form trade unions like ourselves, doctors. Doctors have a very vibrant union, the KMPDU. Teachers have NATs, and lawyers have LSK, lecturers have WASU. But police officers, they don't have a union, but they also don't have any welfare association. I think there are conversations around welfare association. Recently, we saw a video of a lady officer, under some distress, complaining about some issues within the police force. So there are some welfare issues, be it issues of salaries, be it issues of housing, be it issues of relational issues at work with their seniors. Police officers have welfare issues that have been known for very long. They have been known for very long. And if you speak to a police officer right now, they'll still tell you that these problems persist. So all these challenges that I'm sure a police officer would articulate better than myself, I'm sure are the issues that lead to stress. But again, one other issue that I also realize is that them having to deal with issues that they're not well trained in, such as GBV and mental illness of the suspects whom they arrest, also distress them. They told me recently that some of the mentally ill patients are violent, and the police officers sometimes don't know what to do with them, because this person is disturbed. They don't have a place to keep them, even in the police stations. Issues of gender-based violence also distress them. Sitting there and listening time and again to issues of people fighting domestic violence, people have been injured, and you being asked to do something about it, sometimes you don't have the capacity to deal with it. So issues of capacity also frustrate our officers. Probably I could go on and on, but I know that these are some of the issues that distress. And we know that stress for a human being is bad for mental health. Human beings can do certainly better with acute stress that happens suddenly and the issue is resolved. But then when you have chronic stress, I'm a police officer living in a bad house, and I'm not happy about my salary, and I'm not happy about some instructions I'm getting. That leads to chronic stress, and chronic stress can easily lead to depression or other illnesses. But lastly, let's also remember that police officers are human beings. So all human beings are also susceptible. So there's no way when you are selecting police officers that you can only select those who will never get mentally ill. So even we must also realize that police officers as human beings will suffer from some of these mental illnesses because they are human beings. But the rate of mental illness among the police, just like other first responders like doctors or in the army, will be certainly higher because of the number of negative events they have to encounter. Santana.
Okay, thank you. You've mentioned a couple of issues that might impact the mental wellness of police, such as frustration, trauma, public perception, carrying out instructions that go against their beliefs. So, and general welfare issues. So there's both internal and external factors. So supervisors, how can their supervisors learn that these factors are, impact the mental wellness of the police?
Yes. Obviously, as human beings, knowledge is gained through interaction, maybe learning, and so on. What I will say is, it will be very important for us in the health sector, maybe working closely with the ministry that is in charge of police affairs, to think of ways in which we can sensitize players in the policing sector on mental health. They need to know about mental health for the purposes of their own mental health, but also the mental health of the clients they deal with, be it the victims of crime, but also perpetrators of crime. They need to learn about mental health for those two important reasons. So those who are already in service should be sensitized. But long term, those who are not in service should also, there should be some effort. And I think it's an imperative that we inculcate, we incorporate mental health within the curriculum of police training. Really, there's no way a police officer will work without encountering issues of mental illness. And so it's very important that this becomes a core part of their mental, their training curriculum, just the way people have talked about in calculating mental, health rights, human rights in their curriculum. Also, you need mental health to be incorporated in that training.
Harry, I'll now hand over to Vincent.
Okay, thank you very much, Dr. for a very enlightening context on mental health in Kenya. I've heard that it is very important that we, the public, understand that the police officers are human beings as we are. They have problems as we face each and every day. So maybe to move now to the next part where we bring in the National Police Service Commission, who are represented by Sarah Muthiga, maybe to explain what role does the National Police Service Commission play in ensuring that mental health of police officers is taken care of, and maybe what policies do we have in place for police officers to maybe hear out issues when they have issues mental health. How can they bring it to their seniors? Karibu sana Sarah Muthiga. And maybe just before Sarah goes, I would like to remind our participants that to continue engaging us on our Zoom platform, and maybe continue asking questions if you have any feedback that you may have for us. Karibu sana Sarah.
Thank you so much, Mr. Kimathi, and Daktari, and also my fellow panelists for this, and Madam Santana as well. First off, before I get into who we are and what we do, I'd like to thank Daktari so much for enlightening, or rather sharing so much about his views, and also views of many about the impact of and the need for mental health among Kenyans and also among members of the police service. I say this because we carefully like to also be sure of the line between mental health versus mental illness, because what impacts the members of the National Police Service, it starts with the need for appreciating the need for their mental health. That is because of the work they do. But to begin, I'll just say, as you mentioned earlier, the mandate of the Police Service Commission is established under Article 246 to actually cater for the welfare and human resource management support for the members of the service. And it's all the way from recruitment, their stay in the service, until their exit. So we are involved in pretty much all the policies around all the policies around the entry, stay, and exit of the members of the service. With that in mind, with regards to specifically this topic of mental health, the Commission has put in place, or rather is cognizant of the needs of the police service. We are also alive to so many issues that are also reported in the media, and also that we happen to see within our internal reports regarding police service officers being involved in very traumatic situations that either they have caused or they have been participating in either clearing and stuff. So with that in mind, what we know is that what causes or what situation causes the need for mental health awareness amongst the police service? And it starts with the nature of their work. What Dr. has mentioned is that it's true, police officers are regarded as the first responders with a lot of crime and incidents involving members of the public and even amongst themselves. And also they have the family environment to take care of. They are also living amongst Kenyans. They also have to abide by the employment practices that exist, which include being transferred to work in any parts of the country, sometimes or many times separated from their families. And this is something they are also alive to. They also are Kenyans and human beings. So they're also exposed to societal issues such as alcoholism, drug and substance abuse, and other factors that we know affect even other Kenyans out there. And therefore, for the Commission and for the institution, as mentioned, we therefore see mental health as two-pronged. The need to identify the need for mental health support and also treat it when it evolves into an illness. So I don't want to belabor the factors, that is the factors that necessitate counseling services or mental health services within the institution, because they have been spoken to by Daktari. And there are many, including terminal illnesses. People get sick and people get injured and they need mental or counseling support. So what has the Commission done about it? Now, apart from the law that covers our mandate, the introduction or the establishment and existence of the Inspector General and as the commander of the police services, and having the laws that exist that cover the existence of the police service and the Police Service Commission, we went further and developed psychological counseling services policies. So within the institution, we have the psychological services policy that actually lays down what is the requirement for police officers to be exposed or to be provided with mental health support at very many different circumstances that are outlined in the policy, which include, to begin with, the issue of prevention, or rather the pillars of the policy are prevention, care and support, and then rehabilitation. So the policy provides for the establishment of a counseling unit. There's actually a Directorate of Counseling Services that exists at the Inspector General's office, whose mandate is to, first of all, respond when there are issues of exposure, say, to a traumatic event. For example, when something has happened on the ground that, we get to see many stories in the news. For example, when an officer has either been killed or has killed himself, or even an officer, maybe like the officer in Nakuru whose house was burnt down and family was also affected, we are able to send the IG is able to send the psychological counseling officers, that's the counselors, down and also work with other agencies to respond within a minimum of 72 hours, just to be able to provide the fast response. Under prevention, there's the issue of awareness creation. Dr. Tari has mentioned he was interacting with police officers in Mombasa. That is one of the awareness activities that we actually want to have discussions with police officers on the ground, so that we can actually have a situation where people are able to talk about the need for mental health. The continuous care and support is provided through counselors who are existing within the service, within public service, and even with partner institutions and other counseling centers that exist. And then rehabilitation, we have in their mental health cover, it includes the provision for rehabilitation should the need arise for an officer needing rehab services. Now, what reporting channels exist? I don't know, maybe I should allow for interjections, but just to highlight that Dr. has mentioned, and it's actually the case, the police service is a command structured institution. So there are service standing orders that guide how police officers are supposed to operate in the field. And among the roles of all the commanders on the ground, it includes being able to identify if there are officers among them who need psychological support. We also have talked about the element of training we have in the service. The role of the commanders is to identify, to refer officers for counseling. They get trained on leadership and counseling skills, and also to ensure that they exercise fairness and transparency in human resource practices, just to ensure that they do not cause more frustration. This is all, I would say, a work in progress. We don't want to say that it is a perfect structure. It is work in progress in terms of we are working on how to improve these services, and we welcome support from all other institutions and partners such as our participants here and other agencies, just to be able to improve what actually exists. Thank you. For now, maybe I can allow you to ask some more.
Thank you, Sarah. Indeed, you mentioned that you put in place or established psychological counseling services policies for the police service. However, maybe if you would be willing, kindly expound what role as the commission played in ensuring that you're creating a conducive environment where officers can share their mental issues they may having.
Thank you. You see, I'd like to say that to begin with, the role of the commission is actually a policy and oversight institution. So we start by implementing the policy, and the first thing the leadership, and that is through the commission and the service command is able to do, is first to identify that we need the policy structures to enable to have the departments and directorates to be able to exist. So those departments and directorates and counseling services exist because the commission and the service were able to establishment and recognize them as the need, as a need for the service, mental health support. Secondly, we are also carrying out or have worked through the service to recruit additional counseling officers, counselors, and even creating awareness amongst the police officers that counseling services exist. And then there's the element of culture. You see, the issue of culture, and Dr. mentioned it, there's a general stigma around mental health. That is in the country, all Kenyans. So what the commission and the service are able to do is, first of all, identify and talk about it and raise awareness that it is an issue that needs recognition. We don't want to say that it is only police officers who get mental health stressors. We all do. But the only difference between a police officer and another Kenyan is a uniform. So that uniform makes these officers have certain authority to be able to do certain things, which is their work in accordance to the law. But now we are basically raising awareness with the fact that, look, you can be exposed to something and you will need mental health support. And therefore, this institution exists and these departments and directorates exist for you to be able to reach out for that mental support. Secondly, the commission has also established the medical board. And the work of the medical board is to conduct routine assessments. Medical board has over time, I would say, been viewed as something that looks at officers or persons when they're already sick or injured and mentally unwell. That is the illness part. But we are now looking at it in terms of there's need to actually have continuous mental assessment. And it is not a bad thing to be mentally assessed. It is not a bad thing to need support, to need someone to talk to. And then another element that we have is the element of chaplaincy. Chaplaincy is more of a spiritual guide, and we have them in the NPS, or rather in the National Police Service, but we haven't really been able to engage the chaplaincy and counseling services across the board. So we just want to make them available to begin with, and then raise awareness that they are available to officers, and then continuously review the policy and see how else we can make these things more, these services more vibrant, and reduce the stigma around the need for mental health support amongst members of the service.
Sarah, that these are conversations that we all have to to engage in, and there's need for partnerships. And maybe my last question would be, after you've implemented these policies, what is the accountability? Who is accountable for to ensure that the policies are implemented? Is it the commission or now the police service?
Actually, you see, implementation and oversight, we have ourselves, first of all, as the developers. We then oversight the service with regard to implementation. And then we are also oversighted by, or rather overseen by the Parliament. We make reports to Parliament, we make reports to the National Assembly, to the Senate, on matters regarding welfare. It is actually an issue we are supposed to report on at least annually, on matters of welfare of police service, which includes the terms and conditions of service, what we put in place to improve the welfare of police officers, and this broad spectrum. And just to add, we have other oversight institutions that you'll see, the likes of IPOA, for example, the Independent Policing Oversight Authority. For them, as much as their role is to look into misconduct conducted, or rather undertaken by police officers, we are able also to work with them closely to be able to assess what could be the trends behind malpractice or commission of certain acts by police officers. So we are able to then track and see jointly what are we able to improve on.
Okay, thank you, Sarah, for that insightful conversation. I will hand over to Santana, who will lead us the next.
We've received a few questions from the participants. One from Danson Mutua. He directed it to Dr. Chitai, but perhaps Sarah might be better placed to answer, because he's asking about the current model of managing mental health in the police force, whether it's effective.
Okay, I can go ahead and answer?
Yes.
Yes. Okay, I would not want to say that it is 100% effective, but I would like to say that it's a start and it's a work in progress. Because remember, we are moving from an institution that did not initially even have the department prominently or directorate prominently existing. Now it has the directorate. What we are currently working on, which is all resource-based, is recruitment of the practitioners to be able to provide this support, or rather these services. So it is not 100% effective yet, but we have started with having the directorate in place, recruitment of the officers, and as much as possible being able to spread them around the country so that they're able to be available when needed. The other factor that we also are taking care of is the element of training. Our commanders, that is all our officers in charge, and it starts all the way from the rank of a corporal who's in charge of constables, all the way until an officer in charge of a station or a unit or a county and even higher, until the IG himself, should be able to identify officers or persons below them or who are serving in the NPS who are in need of mental health support. Because as we've noted, the triggers are many, and Dr. spoke to them. If a person is, for us, maybe in our less, us who are not in the police service, so to speak, you would be able to maybe identify among friends who is not maybe feeling so well, and even provide an avenue to talk about it. But remember, within the National Police Service, it's always response. They're always responding to crime, responding to maintenance of law and order, etc. So we need our commanders to be able to identify what are the triggers or what are the symptoms of someone needing mental health support. But at the same time, with regard to prevention, we also want to introduce and have a more vibrant approach towards what can we do before the mental health breaks down, so to speak. For example, when an incident has happened, what is the immediate thing that an officer should be able to do? In other countries, which we've been able to benchmark with once in a while, is that whenever there's an incident involving, say, a firearm has been discharged, there's immediate counseling services, or the officer is expected to speak to a mental health practitioner, just to be able to assess that the officer is okay to return to work. Now, that is very resource intensive, because as you know, this country, we have a lot of things happening at the same time. So you can imagine mental health needs to become a frontline response issue. So Would I say it's effective? Not yet, but it's something we are all working towards. Thank you.
Okay, thank you. So what I'm hearing is it's something that will be realized progressively, not in one day or even a year.
Yes,
Okay,
thank you.
I'll also move to the next question from Emmanuel Kiprono. He's asking, how is the documentation and research skill on mental health in Kenya? Perhaps Dr. Chita can answer this.
Yes, thank you. I'm not sure if I got that question right. Could you just repeat?
Emmanuel Kiprono is asking, how is the documentation and research skill on mental health in Kenya?
So that sounds like more of a general question about mental health research and not necessarily about the police, if I get it correctly.
Yes.
Yeah. So okay. Well, I don't know if I have a very good answer, but the problem with mental health and not just research is that there's underinvestment in mental health, and I can tell you that research is an expensive endeavor that requires a lot of resources. However, if you look at, for example, the allocation to just mental health over the last 6 years, it's been meager, it's been erratic, it's been less than 1%. It's been actually less than 0.5% of the health budget, against an ideal of maybe around 13%, which will reflect the burden of mental illnesses in Kenya. So mental illness account for like 13% of the burden, but when it comes to the budget, mental health is allocated less than 1%, actually around 0.5% of the budget. So as you can see, the allocation is so little that even the research that we do is very little. A lot of the research is also dependent on students who are doing master's degree levels or PhD degree levels that is not maybe very well funded, and it could have some logistical problems. Someone will, for example, say, okay, I want to do some research among the police, and there are students doing masters. They may not have the capacity to actually research on all police officers in the country. So they'll do research in Nairobi. But you know the problems of that. Nairobi is not generally a hardship area. So will the problems of police in Nairobi reflect the problems of police in Mandera or Lamu or in Turkana? Probably not. And so sometimes the research is limited by resources, and therefore it may not be very reflective of the actual conditions on the ground, which could be way worse. So we need to invest more in mental health research in this country so that we get data that reflects our true situation. However, I'm grateful that a lot of my colleagues are also doing research. For example, there's a research on prevalence of mental illnesses done by Dr. Koba in 2017 that has and that reflected that anxiety is actually the commonest issue. Mental illness in Kenya, followed by depression, followed by substance use disorder. So in that order, so at least we have some research going on. We have the Africa Mental Health Foundation, led by Professor Ndetei, that does a bit of research as well, and then we have also some research coming from Cambridge. However, we are doing a lot less research than we need to because of issues of resources.
It's unfortunate that is not investing enough in mental illness, considering the rising cases of suicide. However, thank you for bringing this to our attention. The research on prevalence on mental illness, we'll look it up after this webinar. We'll now move over to the next session. We'll hear from Senator Kasanga. Senator, please tell us why mental illness, the topic on mental illness is very important to you and Kenyans at large, considering you introduced the Mental Health Amendment Bill 2018 to Parliament.
Yeah, thank you. Thank you so much, Santana and Vincent. Thank you, ICJ, for having this conversation. Thank you to Dr. Chitai and Sarah Muthiga I really consider myself very privileged when I sit in these panels because I get to learn a lot and I get to carry a lot of talking points with me. Listening to Dr. Chitaye, especially when I listen to the experts in the mental health field, you really learn a lot and you carry a lot. And I have to thank ICJ for these platforms because we all carry something with us. And this is how we are saying for us in the advocacy field that we need to talk more about mental health. We need to fight the stigma by speaking about it. We need to bring the issues to the fore so that we can begin to put pressure on government so that we can seal this gap that Dr. Chitaye is talking about, the underfunding that has been going on in the sector. And for me as a legislator, Article 43 of our Constitution is very clear that every person has a right to the highest attainable standards of health. And Section 73 of the Health Act 2017 provides for establishment of a mental health legislation, one to protect the rights of individuals suffering from any mental health or condition, ensure that the custody of such persons and the management of their estates are necessary. Secondly, to advance and the implementation of measures introduced by specific legislation in the field of mental health, and of course, to ensure research is conducted to identify factors associated with mental health. And of course, lastly, to establish, manage, and control mental health facilities, making sure they have sufficient capacity to serve every part of the country, national and at county level. So you can imagine already this is stipulated in our legislation, in our constitution, but we have not done so. Now, the current Health Act that is in force is the 1993 Act. But it is so outdated. And in fact, it looks more at mental illness rather than mental health. And I think Sarah and Dr. Chitaye have made it clear that there's a clear distinction between mental illness and mental health. And you know, this 1993 bill has no delegated function of county governments and national government under our new constitution. So it has never really been brought to the current dispensation. And this is part of the reasons why I went into this particular field, because then I saw the gap out of my own personal research, out of questions that have been asked to me by, you know, some youths who came from Makueni. And I said, you know, let us then delve into this particular sector. Let us talk about it. Let's speak about it. I didn't know much about it myself. My background is one of construction. So I went through a bit of learning at the beginning of our research work. And we established that indeed there was work that needed to be done in terms of legislation. So it's very important that we look at this subject wholesomely. I know today you're speaking only about the police force, and in our advocacy work and in the work of the legislation and even the legislation that we have sponsored in the Senate, it is a multi-sectoral approach. It has to be looked at from very various angles, and of course culminating to the funding of it under the health budget, because health is a devolved function. And so I can just say that in a nutshell. I don't know if you want me to go into the specifics of the bill, but maybe I'll give it back to you, then you can ask any more questions.
Okay, thank you. Indeed, I also agree that we should look at this wholesomely. So kindly give us an overview of the bill, because you're very well versed with it. The Mental Health Amendment Bill 2018.
Yes, now it's actually the Mental Health Amendment Bill 2020. Because what happened was when we were done with it in Senate, it went to the National Assembly and it was deemed a money bill. There were certain aspects of the bill that they felt was a money bill, and money bills cannot come from Senate, and therefore it technically died at Senate. But when Senate went to court for constitutional interpretation of money bill, there was an agreement that once the two speakers of the houses have consented that a bill has nothing to do with money or is a bill for the county, then it cannot die in the process. So it was brought back again after the concurrence was done. It was reintroduced again in Senate. And I'm happy to say right now we have just done the second reading of it. It has still elicited a lot of response. We got a lot of public participation, even the second round. And therefore, the bill that we had in 2018 with the bill that we have now in 2021 is very different. It has really grown and metamorphosed. It has been enriched by a lot of stakeholders. A lot of stakeholders have come in to enrich. And one of the other things I can say is that the ministry of Health has finally also come on board in this session, in this second republishing of the Mental Health Amendment Bill. The ministry has now come on board. They've even brought their own submissions, and they've come in support of the bill, because as you know, in the task force report, there was a recommendation that they support the initiative because it is a good initiative. It's a very comprehensive bill, and I'll just highlight on some of the issues of it. And it's just good just to take note of how far we have come from the time we started this process in 2018. That even now, currently, even after the president had gazetted the task force, and the task force has published their report, which is a very comprehensive report. And it's a report that I always encourage all Kenyans, to go through it and read, because then you can understand the length and the breadth of the issues that affect Kenyans and their mental wellness. The president has further gone ahead to gazette his advisor, his personal advisor, Dr. Njenga, is the personal advisor on mental health to the president. And it was Dr. Njenga who got Parliament, that is now myself representing the Senate, and the ministry to sit together and agree to disagree on certain areas of the bill. And it was a very healthy conversation. And it's a sort of conversation we always say that, privately sponsored bills should be able to be appreciated by government, and the two should come together and produce a bill that is then good for Kenyans. So the overview of this bill is a very comprehensive bill. It looks at the rights of persons with mental illness. And this is very critical because the original bill did not look at this aspect of it. So we want to protect physical and mental abuse of mentally ill persons. We want them to have the right to the highest attainable standards of mental health services, because they are recognized under the Bill of Rights as full human beings in their own capacity. They have a right to participate in treatment planning. They have a right to access to medical insurance. They have a right to consent to treatment. They have a right to confidentiality. They have a right to access to information. This is a very, I started with this because it's very unique, and it is what makes our bill a very comprehensive bill in bringing the rights of persons with mental illness to the fore. They come now to the front, as opposed to what we have seen in the previous bill. This bill also just seeks, to delineate the two functions of the national government and the county governments. And a lot of weight is placed on the county governments because health is indeed a devolved function. Now, a lot of research has also shown to us, and Dr. Chitaya has mentioned one, Dr. Ndete, and a few other organizations that have been doing, research in their own, little bubbles of mental health. They all do their research based on their particular interest in mental health. But Dr. Ndete, Professor Ndete, has done something interesting because he has rolled out a community-based approach towards mental health and mental health treatment in Makueni County. And it is largely showing that a community-based approach towards mental, health is more critical than establishment of more mental health facilities. So this bill seeks to integrate mental health into the primary healthcare system. So what Dr. Chitayi was saying, that at any one time you should be, open enough to say, hey, I'm going to see my psychologist. Or for instance, if you go to hospital and you run some tests and they cannot find anything physically wrong with you, then there's a mental health practitioner within the facility who then can also look at you. So you get a wholesome and comprehensive consultation when you go to hospital. So the bill seeks to integrate mental health into the primary health care. So we are talking about level 1, level 2, level 3. And in the process, then the referral system works. So then that any advanced cases are then referred to level 4 and level 5, where then you find the advanced practitioners and the psychiatrists at that level. And that's also very critical, the integration of that. And it calls for the county governments to really do a lot of work, the multi-sectoral approach towards mental health, that is in the schools, in the school curriculum, in the fighting of stigma through policies and other programs that then the county governments can introduce that then they can run, and including a board or a secretariat at the county level that then draws up the methodology of approach to each county, because each county is unique to itself. And it's always good to say that there are some counties, even before the bill comes to the fore, they have listened to to the cries of Kenyans, and they've gone ahead to, put aside a budget for mental health. Makueni being one of them, which has rolled out a very good program for their citizens there. I know Kisumu County has been partnering with a lot of community-based organizations to help them roll out policies, on how they can tackle mental health issues that are unique now to the Western region. And because Kisumu, covers the larger Western region, so they have a huge population that they need to look into. So these are some of the things that the bill looks to do. And of course, many others. I wouldn't possibly go through the whole length and breadth of it. At national level, we expect that the national board would then roll out national policies, would be the place for research, where research happens, and the record keeping, where you expect that the county governments report back to the national government on their statistics and things like that, and all those other issues that are part of the bill. I could speak on the whole day about it.
Thank you. The bill has quite some progressive provisions, such as the integration of the mental health to the primary healthcare system, and also the rights of persons with mental illness. For example, like the right to access information. During this COVID period, persons with psychosocial disabilities were actually victims of police brutality. And probably because they're unable to understand these measures. So I thought that is very important, that we need to take into account their disabilities in understanding some of this information.
Yeah, I have to just, when you talk about that, there's actually provisions now in the bill for supported decision making for somebody who is very ill, who can't understand. There are provisions for that. There are provisions for the guardians. There are provisions for representatives as well. All that has been canvassed and looked into, because what happened is during the creation of the bill, a lot of research happened between the drafters of the bill. They did a lot of research to get best practices from across the globe. And these are some of the best practices that we came across. They're very progressive. They might not happen in the immediate time, but over time, that is the direction that indeed we should go as a people.
Okay, thank you. So how do you think this bill will improve the mental wellness of police officers in the event that it becomes a law? In the event that becomes a law, how do you think it will impact on the mental wellness of police officers?
I think looking at it first from the citizenry side, it's the level of awareness that we should all have as citizens towards mental health is going to help one another. Let's just start there, from one another. The kind of the methodologies in which we should be interacting with ourselves as citizens in a big way will cut across everybody, both citizens and the police as well. I mean, we've seen videos of, brutality against police, for instance, gang mentalities and, things like those, whether the mistake was from the police side or otherwise. If these conversations of mental health and mental wellness keep going, and we institute mechanisms in which we are all aware of, the impact of your actions on somebody else's mental wellness, that may go a big way to help. But on the other side, now looking at it from the police side, the access to the mental health care is a big win, not just for police, but for Kenyans. But specific to your question, access to mental health care is very critical. And the fact that insurance will cover, the different kinds of mental illnesses, both at outpatient and inpatient, is a big win for everyone. Because this means now we will have even more practitioners available for people. We'll be able to do rehabilitation and reintegration. Say for somebody who's been to an institution for any reason, when they come out, to reintegrate them back into the society. These are things that will begin to become possible, and they will help not just the police officer and his family, but the larger community as well. So there are very many wins when this bill becomes a law.
Okay, thank you. Perhaps while you were conducting the research, you read on practices in the region, or maybe you can enlighten us on that.
Our regional, actually the thing we borrowed from our regional neighbors was from Rwanda, Kigali. Rwanda, Kigali has had, because of their genocide history, they have made certain strides. They don't have it in legislation, but their practices. The governments have made sure that they have methods of dealing with, say, trauma post-traumatic stress disorders and gender-based violence, for instance. They have methodologies of dealing with these issues and ensuring that there's access to justice as well in cases of gender-based violence. And these go a long way to helping people who've been afflicted. So you find that they have created these centers regionally, where in case somebody is distressed or you don't know what to do with somebody, say, who's having a certain mental episode, there's a place where you can actually take them in that center. In that center, there will be a psychologist who will be able to take them on. If it's in the case of gender-based violence, then they're able to rescue the person, they're able to, get evidence for whatever it is that they need to get evidence for, as well as do psychosocial support. So you find that they have these structures that they've already set in place because of their genocide history. Most of our research, of course, came from South Africa, Egypt, and abroad. And a lot of it, of course, has to do, again, like with the community-based approach. They are really knocking down the institutionalization approach to mental health because of the stigma that it carries with it, and probably the challenges of reintegrating people back into the community, into the society. So the approach now is more on preventative. Let's have these conversations. Let's have them at home. Let's have them in school. Let's put them in our curriculum. Let's start talking about mental wellness. What are the things that you can do to make sure you are mentally well, you're aware of yourself enough to be able to track, like what Dr. Chitai was saying, that you can know when you're unwell, or when you can know somebody next to you, your child or your partner is unwell. Then you begin to deal with it from that level before it escalates into anything more, more severe. And of course, they have integrated mental health care in their healthcare systems. In fact, many times when you talk to people in the West, speaking to a psychologist or a psychiatrist is as easy as saying, I'm going to see my dentist. That's what Dr. Chitai was saying. And those are the places that is the place where we need to reach by completely breaking down what is mental wellness and what is mental health, what is mental illness. The minute we all begin to understand what it is, that then it is just an illness that you need to understand and you can seek help with, then it breaks that barrier that stops us from coming out and being open about it. And we will really need to reach there. Yeah.
Okay, thank you. Perhaps if Kenya as a society can borrow some of those practices, the stigma will be less. Inculcating it in our curriculums from school. So,
and
on that,
if I just add, including the workplace. In fact, part of the policies that are the conversations that are happening around policies include mental wellness in the workspace. So just not in schools, not just in the police force where they're already doing some things and they're making some strides. I know in the army, they're also making some strides on making sure there's enough psychosocial support and approach towards, mental health care. But the workplace is one area that a lot of private sector and even government, places that have missed out on this psychosocial support for their workers. And this is very critical. The faith healers and the churches are doing a very good job when it comes to, again, this conversation on mental health. So the workplace is the one place where it is kind of being left behind. And I remember when we were doing public participation for the bill, we even had the Fraternity for Human Resources. They came and made a presentation that indeed there must be a policy that mandates all workplaces, just the same way you have a business license, you must demonstrate psychosocial support that is present in the work area.
Okay, thank you. And on that note, you've given us some very good suggestions, but what role do you think civil society can play to ensure that the mental wellness of police is taken seriously?
Civil society already is doing a lot of work. In fact, we had several organizations who came for public participation, and they have worked with us in the course of this, doing this advocacy work and creation of the bill. There are actually several civil society organizations that brought in their own, submissions on the bill on where to improve. It is in fact their work that made sure there's a section of the bill that deals specifically with our men and women in uniform. There's actually a specific part of the bill that was brought in by them so that they can be sure that our men and women in uniform are covered for when it comes to the mental wellness. So they have been very vocal about it. And what I can say, and what I always say, as I advocate for this, I keep saying, let us continue talking about it. Let us have more forums where these conversations happen. Anytime the government calls us to sit down, representation must be present. You must not miss out on any conversation on mental health. That way, then we can make sure all the interests of all different groups of Kenyans are catered for and covered as the conversation continues to unfold.
Thank you very much, Senator. I'll now hand over back to Vincent.
Okay, thank you very much, Senator, for that and very insightful conversation. And the steps that we've taken as a country, at least we are making baby steps that is a general consensus from all the panelists. And even as I'm looking at the questions that are being put by our participants online, and even the comments, there's a general consensus that mental health is an issue, and it's an issue that we cannot shy away from addressing as a nation. However, to address mental health, we have to take up as a multi-sectoral initiative where each and every one of us has a mandate to ensure that we start taking mental health seriously like we do take other diseases. In this session, I will go through the comments that we are receiving from our participants online who are really doing a good job. Kindly continue with this conversation and engaging us. We have questions that I'll direct to various panelists. Please continue asking questions. We will address them. And let's not stop this conversation here. Let it continue even after this webinar, because we need to keep this conversation alive. Maybe I will start with the question from Karen Mwangi that I will direct to Sarah Moviga. Karen is asking, what practical therapeutic interventions are taken on the affected individuals in the police force? And maybe to tie that question with the other question is, are we encouraging the officers to take personal responsibility on their mental health? Maybe, Sarah, you can address that question so that I move to the other questions.
Yes, thank you, Vincent, Kimathi, and thank you, Karen, for your question. I like the question in terms of, first of all, is it the question about what are the practical interventions? And I think first and foremost, the practical interventions for mental health support is actually providing the psychosocial support services. The first thing when you get sick, first of all, is to identify you're not feeling well, and then to go see a doctor and perhaps get some support for it. And most of us, I mean, it's not encouraged, but most of us also go to Dr. Google to find out what is happening with me, am I feeling okay, and what the issue is. And that is where personal responsibility angle comes in. The first thing I would like to say is that for practical therapeutic interventions, we first say is that we want to encourage police officers, or rather not only police, but also Kenyans and the public generally, to identify and see that exposure to mental health risk is it happens to anyone, it can happen to everybody, it can happen to anybody. Therefore, what do you do about it? So I would start by saying that the first practical intervention is to actually provide the environment that recognizes that it is a risk that our police officers are exposed to, that we understand that the job can expose you to certain psychological challenges on the job itself, plus the environment within which that the officers have to work in, being away from their families, and also making decisions that may not be, so to speak, what the majority wants. So the first therapeutic intervention, and I'm not a doctor, is that are we providing the psychosocial support? Are we providing the mental health support that is required? And then I want to say is that, are we encouraging officers to undertake personal responsibility? Yes, in addition to the support provided by the institution and by the government. The reason is because a person first knows that they're having a mental health challenge, may not know, let me start by that, but we are saying the job will expose you to mental health, will expose police officers to mental health challenges. So we want to say that first and foremost, anytime there's an incident, any officers should be aware that this can affect people in different ways. So accept and acknowledge that it is something that has happened to you or you're exposed to. So I would say yes to both. There are there are therapeutic responses. We are providing the mental health doctors and counselors for it. But the thing is, we need the officers to be able to approach them when the issue happens. So that in the event that the resources are not available to be able to see everybody at the same time, we would be able to say, if there's an issue, who do you go to and how do you get to that person? And are we encouraging the personal responsibility? Yes, in addition to our responsibility. We are not saying we are leaving officers to their own mechanisms. We're just saying it's an additional provision to be able to recognize it and do something about it. Thank you.
Thank you, Sarah. Indeed, it is our personal responsibility as well as we are tackling this issue. As an individual, we have to see to it that you need to seek help. However, we have to create platforms where people can openly have conversations on this issue. Maybe I'll move to the next. It is more of a comment from Onyango Otieno, who says that police definitely face intense trauma that continues to be unresolved and unattended to. If we don't have political goodwill to cater for the mental health of police officers, it's going to get worse. Evans Yogo Ochele says that a very good initiative. Thanks for the insightful approach to handling mental health issues amongst our uniformed personnel. Then we also have a comment on Twitter from Sylvester Omondi, who says that the essence of having a police college is to build consistent lifelike scenarios of all policemen's life consistently for 2 years for physical and psychological preparedness. While it is a difficult job, it must be done. Then Emmanuel Kiprono says that in Kenya, the Ministry of Health budget allocation for mental health is just 0.5%, of which against 13% burden all over the country. Are we really serious as a country in management of the mental health? Then there's also a statement from Samora Ogendo that is directed to all panelists, and he says that the command structure in as much as it's helpful in the security sector, it is also the greatest undoing in matters welfare, because one cannot challenge an order because it will be seen as indiscipline. Maybe Sarah, you can respond to the statement, because it is more directed to the command structure that we have in the police.
Thank you, Vincent. You see, I like the earlier comment about the fact that the training is supposed to actually prepare officers for certain scenarios. That is, first of all, we are very much alive to that circumstance. And that is why anything that we are doing is because of let me say, recent recognition that there is also need for mental support, healthcare, and support with regard to the work that police officers must do. Well, with regard to the issue of command structure and it's the greatest undoing in matters welfare, I don't believe so, because we also recognize that even in the service standing orders and all instructions coming from the Inspector General all the way to all the commanders and their officers is that a commanding officer is also the welfare officer. It is also, the officer is supposed to be cognizant of all the needs of the police officer in as much as they're also the ones giving them instructions. And another thing is that officers are only given lawful commands. They're not expected to do anything that is against the law. So ideally, if challenging an order is not supposed to be seen at the same time as being in discipline, unless the order itself is an unlawful order, which is not supposed to be the case. So as much as we need to temper the arguments with regards to the need, the training that officers are given is they're supposed to undertake their work and lawful to maintain law and order. And also at the same time, we are recognizing that there is need to support them when they encounter traumatic events. But at the same time, challenging orders is not encouraged. You're not being asked to challenge orders, and it's not a welfare. It's not supposed to be read alongside seeking welfare accommodations or welfare provisions as a police officer. So we look at welfare as your we talk about welfare, but what is welfare? Welfare is you as an officer, or you as a public servant, or someone who's in the ordinary course of duty, is undertaking their work in a work environment that allows them to be able to do so. So we are saying, as the institution of the commission and the service, we are trying to put in place welfare provisions that take care of an officer's well-rounded approach to how they do their work. That is not supposed to be seen as something which officers should therefore say that seeking to have the mechanisms or the work environment good should not be seen as indiscipline. It is not related. Commands that come from their commanders are about obeying the lawful orders that exist in this country. Thank you.
The NPSC is taking steps, and we hope that we will see all these steps being operationalized and implemented as well. So I will move to Emmanuel Kipronos, who says that Senator talk about mental health among legislators and fellow leaders. How can we have them join in this conversation about mental health? And he follows that question with mental health seems to be addressed very well among leaders and as a country. Could you mobilize advocacy groups so these conversations go another level and more actions can be taken? Senator?
Yeah, I think I need to mention that this is very critical as part of the advocacy work to get them other legislators to be fully seized of this issue. So what we did with the help of some CSOs is to have training sessions for our members of parliament. So senators are very well briefed, and in fact, if you are ever to follow some of the conversations that happen in parliament, you will know that mental health is one of our most talked about subjects in the floor of the House. And the statements, when the comments they come asking about different groupings of Kenyans. For instance, you'll hear a question being asked about mental wellness for the police. That has been addressed severally on the floor of the House, with several recommendations coming out of the House. And about children, the children issues and their mental wellness has been addressed as well in the floor of the House. And we've had a very healthy conversation as senators when it comes to mental health. And even as we were debating the bill, the 2 times that it has happened. For National Assembly, the bill will be going to the House. And I know the Committee of Health for National Assembly, actually we did a bit of a training session for them when the bill first went around to them. And we intend to do another round of training. We call it training. It's a basic training on mental health for them to understand. And then lastly, the SDG caucus of Parliament, the Sustainable Development Goals caucus of Parliament is now fully seized of mental health. And in fact, we've been having a series of conversations that is happening where the parliamentarians come together, both National Assembly and Senate, to discuss matters mental health, to the point where we're even sitting with committees of Parliament. We're sitting with certain government entities. Now we are rolling out the second phase, where we'll be meeting with different government entities to discuss on matters of funding for mental health and to put pressure. So your leaders are fairly well versed. We had a rollout of a program we call the Fungua Roho campaign, where we have our legislators come and train, a series of trainings where they begin to understand about mental health. And we use them now as our ambassadors. So we have ambassadors of mental health in both National Assembly and in Senate. And this is a conversation we are saying that must only continue to increase in volume rather than decrease. So we are very well versed with it, and we shall continue with this kind of advocacy.
Thank you, Senator. It is good to hear that we have champions of mental health in amongst the legislators, and slowly by slowly we will get goodwill of the same. And thank you, Senator, for the work you're doing. Maybe now I will move to the next part where I will invite our panelists to give parting shots and way forward. I will start with Dr. Chitai, then Sarah Mudhiga, and then Senator would go last. Daktari, please.
Thank you, Vincent. Thank you, Vincent, for organizing this session. And I would like to thank my fellow panelists and all those who are able to join this session. In my conclusion, I would like to say that mental illness is an issue of human beings. Police officers are human beings, and therefore police officers will inevitably face issues of mental illness. They'll also deal with mental illness in the course of their work. This is a good beginning, having such conversations, but we should go beyond these conversations and also make demands about making actual investment in mental health. However, that's not to downplay the role of such conversations. And ourselves as the Kenya Psychiatric Association, we are taking part in educating Kenyans about mental health. In this month of May, we have a mental health awareness campaign under the hashtag of mental health 254. And interestingly, we are also talking about promoting positive mental health. And that's to say that this conversation should not always be about the illness, but it can be about ensuring that people have good mental health. Those who have good mental health can have it improved further, so that we increase their chances of preventing mental illness and enjoying well-being. Thank you.
Thank you, Daktari, for that. Sarah?
Thank you so much for this opportunity. I want to sincerely thank ICJ and all the membership for coordinating this, for setting this up. We are not taking it for granted. I mean, this is a conversation that should keep on happening, and we thank we thank you for also bringing together the legal fraternity to also start talking about this. I want to thank my fellow panelists. I've learned so much. I mean, I like the work of the psychiatrist is not unsaid, but I'm even very much more impressed by the work that the senator and her team are doing. I mean, I would be very glad to partner closely with you, madam, for additional discussions, and even the welfare of police and other uniform discipline services being brought in as a prominent discussion in both houses, and specifically for you in the Senate. Regarding what I would say, the call to action I'd have for this team is that we need to also recognize that, yes, police, we are doing we are doing what we can, what we should, and we remain committed to ensuring that the environment that police officers are working in is conducive for them, and even their welfare is well taken care of. But we want to also encourage the role of the community, the role of partners and other stakeholders to also help us to identify, resource, and even support the mental health care for police officers. We are not shy to say that when police officers serve well, are served well, that is within us offering what they need, they're able to serve members of the public well. And that is the priority that the members of the service have. That is, they want to serve the service, the commission, we want to serve the members of the public in the way they should be served. And in so doing, we'll all be able to enjoy a secure country. So thank you so much for this conversation, and we remain committed to continuing this conversation and towards active and actionable points. Thank you.
Thank you, Sarah, for that. I will invite Senator.
Yeah, let me also just join my panelists to thank ICJ for this platform and to encourage you to continue with this conversation. It's the one thing I always say, let's increase the volume, let's talk more about it, let's demand accountability from every quarter of the way. So I look forward to more conversations like this on this platform. I want to thank Dr. Chitai in a special way. I always learn a lot from him. Every time I listen to him, I have a whole load of notes that I take with me that hopefully I can use as talking points in the next session where I go. And of course, Sarah, I am open to, of course, meeting and having this conversation. We shall reach out to you. We will find you and we can call you in, and then we can see what else we can do together. Because the advocacy for the members of parliament continues, and it doesn't stop from adding more pressure, even if it is coming from one specific avenue, so we can help where we can help each other. And to our listeners, thank you all for staying put and listening. I've seen a question there asking where they can get a copy of the bill. The bill is present in the portals for Senate. You can get it there. If you go to my personal page, you can also get it there. In my personal page on Facebook, you will get a lot of other material that we have used in the process of creating and making this bill. And to Kenyans at large, my message is always a goodwill message, that let us be gentle to each other. You don't know what the person next to you is going through. Let us be aware of our environment so that we can begin to help one another and to hold each other's hands and to encourage, this conversation to go on. So thank you very much for having me. It's been quite an honor to participate. Thank you.
Okay, thank you very much, Senator. Please keep your doors open for us. We'll be knocking at your doors to continue this conversation. You are our champions. I will hand over the session to Santana to lead us in the next part.
On behalf of the ICJ Kenya Council and the Secretariat, I extend my sincere gratitude to our distinguished panelists. Thank you, nominated Senator Sylvia Kasanga, Dr. Boniface Chitai Murabula, and Ms. Sarah Muthiga. Finally, I extend my gratitude to all our participants for joining us in our webinar today and for your active engagement, and our entire production team for your great efforts in putting this together. Until next time, asanteni and have a great afternoon.